a personal present from me, this chart. I would recommend for you that you ask somebody or you yourself print it on a large format paper, A3. And why not laminate it? So you have this in front of you when you're screening. We have the tool scientifically proven. If we steal time from cancer, we go back in time, then we save lives. Now that's called screening asymptomatic women. But out of 1,000 screened women, let's say age 40 to 74, you only have 6 or 7 cancers. So what are you going to do when the 994 cases are in front of you? Well, you can make a huge mistake by recalling her and her and her totally unnecessarily. That is really working against the screening principle. How can you avoid that? We are going to talk about those 4 basic building blocks that build up histology and build up the mammogram. But their combination is innumerable, and it's called asymmetric densities. And that is the biggest problem and explanation for unnecessary callback. Let's talk about the 4 basic building blocks. Histology is nothing else but the color mammogram, and the mammogram is nothing else but a black and white histology. Please get acquainted with this basic principle. A modern 21st century pathologist never signs out a histology report without looking at a mammogram or talking with a well-trained radiologist. And after that, they sign it out. Histology is not an entity by itself. Mammography or ultrasound or automated breast ultrasound, MR, and so on are not separate entities. We have to work together. And for that, we have to understand the 4 basic building blocks. And dear colleagues, they are right in front of you. I'm going to talk a lot about the so-called 3D pathology. What does that mean? Your pathologists are using the so-called small section histopathology slides. Unfortunately, this is outdated. What I'm going to show you and entertain you with also in real time is the large section histology. Our glasses measure 10 centimeter by 8 centimeter. Or it's much easier to implement the so-called mega cassette. Every modern pathology institute should have it, and say goodbye to the small section histology, because you cannot compare with this one. This is 7.5 by 4.5 centimeter mega cassette. Very easy and relatively cheap to change your available small section histology technique to the mega cassette. The 3D pathology is different, not in size. The size is the same, but it's thick. We call it thick section or 3D or subgross histopathology because this measures 1500 micron. The conventional histopathology image shows you 4 micron. So the colleagues, the pathologists, can look at the cellular details. There are no cells on the 3D pathology. Here is a picture, here is a picture, and here is a picture. But the 3D pathology, the subgross histology, is vital for the radiologist. Why? Because we don't see cells on the mammogram, but we see structure. The milk factory is in front of you. This is the terminal duct, and this is the lobule. If you add the lobule and the terminal duct together, you got the terminal, ductal lobular unit. This is the most important basic building block because the milk is produced there and it's running out through the terminal duct, subsegmental ducts to the mouth of the kid. Also, 75% of cancers originate here. When you see a stellate lesion, non-palpable 10 millimeter, central tumor mass, straight speculations. Unfortunately, the colleagues, the pathologists, call it invasive ductal carcinoma. But if it originates from here, this is not a duct. So the term invasive ductal carcinoma is a misnomer. It should not be used. So-called hyperplastic breast changes, cysts, fibroadenomas, different types of adenosis, sclerosing adenosis, blunt duct adenosis, and so on, all originate from the TD area. From the major ducts, only the radial scar originates as one of the hyperplastic breast changes. So let's go back to the normal, because this is what the radiologist is exposed to. 994 times you and I need to say normal. Well, of course, we cannot do that. We cannot just pick the 6 cancers, because there are the radial scars and other arch enemies of the radiologist, the cysts, the fibroadenomas, the papillomas, the different types of adenosis. Nevertheless, even if we say out of 1,000 screen, there will be 40 that need to be called back, it's still 960 times you have to say normal. How can you do that? Because you know the basic building blocks. Number 1, the most important, the terminal ductal lobular unit. I immediately project it to the mammogram. Dear colleagues, the size of this is 1.5 millimeter. Within that, there are the acini, and there are 50 or 60 of them, and within that, there are the luminal cells that produce the milk. So all these 1.5 to 2 millimeter nodular densities on the mammograms are the terminal ductal lobular units. And then we are going to be able to see the duct and its branches because they are linear densities. Dear colleagues, these two are called the glandular tissue, but they are not hanging in the air because there are 2 connective tissues, the adipose tissue and the fibrosis that surround the glandular tissue. Certainly, if it's fat adipose tissue, that makes the radiologist look like this. If it's fibrous tissue, then every bit of the normal structure is going to be hidden. That makes the radiologist very unhappy because we don't see the normal details. We don't see the pathology either. The best way of teaching radiologists, and why not pathologists, is the 6-section histopathology. This is in front of you. Galactogram, the contrast media, outline the ducts, subsegmental ducts, terminal ducts, and the terminal ductal lobular units. On 3D pathology, it looks like this. This is the subsegmental duct. This is the terminal duct. And here are those many acini, singular acinus. Radiologists say, I can see this. And it's here. But it's separated from another one with this radiolucent black. That's fat. And here is another one, and here is another one, and here is another one. Yes, we can see ducts, but just like on a tree, there are few branches, but there are zillions of leaves. And that's exactly what the female breast needs as well, namely a lot of milk factories and just a few ducts. And if I see fat separating one TDLU from another, then I can say, this is a TDLU, this is fat, this is a TDLU, this is fat. But here, for example, there is a lot of fibrosis. I cannot distinguish them. And that's why basic building block called fibrosis, in front of the pathologist, it's red because the eosin staining it red. It hides the TDLUs, hides the ducts. And when cancer develops, even that is hidden. We are going to talk about all these, but you have a lecture about the solution to imaging dense breasts. I'm going to show you quite many pictures where I compare the 3D pathology, this one, with plants and flowers. How come? It is because the function here is very similar to the function here. But the direction of fluid transportation is different. The water comes from the ground to feed the leaves and the buds. Here, the milk is produced here, and the transportation goes in the opposite direction. But otherwise, the function is similar. That's why the anatomy is so similar. We published 10 3D books. I wish you had them. You can. There we compare the normal structure with Mother Nature. You can open the book, and on the first page you see stereoscopic glasses, and on the opposite page there are two pictures with 15-degree difference photographed. So it's going to give you the 3D effect. And one of my teaching courses in Italy, the colleagues viewing this book, like this. Here is the forehead, the eye, the nose, lips. Through these stereoscopic glasses, you can see on the facing pages the two pictures. There are no cells here, but there is structure. The TDLUs. You see this yellow? That's the fibrosis. You see this white? That's the fat. And the linear density is the duct. So you have all four basic building blocks. And when concerning pathology, it is just admirable how much more the 3D pathology can see. Here is an elderly lady with this palpable high-density spherical lesion. When the surgeon removes it and the pathologist slices 4 micron in order to be able to see the cellular details, that's correct. But the 3D pathology is 1.5 millimeter. So you see here the intracystic papillary growth, but also the cancers here and the surrounding. But look at the 3D. It shows you the tumor vessels, the papillary cancer, and all these quickly produced tumor vessels that are feeding this cancer. I don't think that pathologists have ever seen these pictures because they don't produce this. That's why we are writing these books. Smaller than 1 millimeter carcinoma. In that picture I showed you, and here is a focus, and here is another one, another one, another one, another one. Very rich picture. The cancer cells send out a chemical signal, give me food. I want to grow. I want to cause harm. And this one, and this one, all of these are papillary cancers in that single picture. I can send you this picture too. This is exactly the same case. Look how poor the mammographic image is. How interesting the 2D picture, that is the 4 micron picture, but how much more educational the 3D picture is. In a single chart, I can show you the ultrasound with the intracystic growth corresponding to this one, what the pathology saw on the histology. But when you bring in the 3D pathology, then you really widen your view. Here is a part of a mammogram. Would you mind detailing what you see here? I see TDLU. I see fat, because otherwise I could not distinguish these. This is what the colleague, the pathologist, would see with all the acini. But we radiologists don't see this, we just see this overview, right? But on 3D, we see it. And this is 1 millimeter. This TDLU is not even a millimeter. And modern imaging tools are able to show these details. And here is my comparison again. That is terminal duct and many acini. Now, the person who invented the 3D pathology was the professor of pathology in Davis, California. His name was Robert Sefton Wellings. I was a very good friend of Sefton. Unfortunately, he died a few years ago. But this is really the basic understanding of what we are imaging. And of course, radiologists, we have to accept the fact that the resolution, being able to show details, is much lower on the mammogram and extremely low on MR. But it's extremely good in pathology. So we have to find a middleman between the superb resolution and the low resolution, and that's the 3D pathology. How do you visualize the TDLUs? I showed you mammogram. But there are some foolish people, and unfortunately they are increasing in number, who go to the witch doctor and they ask percutaneous silicone injection. They are going to feel sorry for the rest of their life because the silicone is going to find its way out. So they are going to have serious nipple discharge for the rest of their life. But for teaching purposes, this is great because I can show you one TDLU, another one, another one, another one, 300, 400, 1000. You see them here. And as soon as you look at the black and white, please think about this. And think about this. Then imaging becomes an art. And this is a duct. And this is a duct. But most of the densities are TDLUs. Here is another foolish case. You see the zillions of tiny white dots. All of them are terminal ductal lobule units. One day they produced milk, and now she got the silicone in because they want to have bigger breasts. Would you mind telling them? This will never enlarge the breast, but it causes you a lifelong problem. Once again, a beautiful picture from the Dead Sea in Jordan. I'm explaining to you basic building block number 2. That's a milk duct. When I'm telling you what's a milk duct, in your fantasy, you think it's going to be a tube. You know what? This is actually much more interesting. First of all the ducts go to the surface of the nipple. Now I have a question. How many openings are on the surface of the nipple? Can any physician tell it? Any woman who was feeding 4 children tell it? No. But physicians should be able to tell it. Once upon a time, namely in 1840, that is about 160 years ago, a surgeon in England, Dr. Cooper, made these drawings. He published fantastic books. This is how he was drawing the ducts running towards the nipple. Do you know the answer? How many openings on the surface of the nipple? The breast consists of lobes. We talked about lobule, but this is lobe. And there are, let's say, 15 lobes. This picture is from 1840. This is my 3D picture. Look at the ducts on a 3D histopathology, running to some of these 15 openings. Now, that's why I'm saying that very dry word, duct, is actually much nicer, much more beautiful when you use the 3D pathology. And the comparison is fabulous with the saguaro cactus in Arizona. You see, it's pleated. Why? Where do women store the milk when they are lactating? Production of the milk is taking place in the TDLU, but there is not enough room to store it. The milk is stored in the ducts. That's why it's pleated, because then it can distend 20 times. You are going to see it. But you see something else as well. It's not only pleated, but also there is a twist on the pleats. We are going to get back to that. You see the twists here? So when the rainy season comes in Arizona, this soaks up the water, looks like a cucumber. And the same thing when the rainy season comes, that is, milk is produced by the TDLUs, that becomes distended. Look at this animation. The pleated resting ducts are running towards the retroareolar region, and they drill themselves through the nipple, and the baby is happy. Here's a cross-section. Here's a longitudinal section of the ducts. Translated this to the language of the radiologist. Of course, they are going to be linear densities. The TDLU was nodular density. And here are these beautiful pleats, once again compared with this plant. Pathologists certainly would appreciate when I'm saying that these are actually micropapillary growth. They are dripping fluid. Slowly but steadily, this pleated duct becomes a sausage, like this, with the micropapillary kin. So just don't call it in situ, because it's not. And here is the fluid. And that the radiologist can see it as a distended linear density. And later on, we are going to talk about the skipping stone-like calcifications, deceptively benign looking, like flat stones. These are malignant type calcifications in the micropapillary duct-forming carcinoma. Do we see the ducts on the mammogram? Definitely. All of them are pointing toward the nipple. Right? Dear colleagues, when the pleats disappear, then it is very distended. The acini were too busy in producing fluid. And that fluid, if it's not milk, then it's because of the apocrine metaplasia. The cells change. Change in Latin means metaplasia. The cuboid cells become cylindric cells, and they are producing so much fluid, and they are sending into the duct. Compare the normal duct, it's actually 0.1 millimeter. It measures 100 micron. But this one, 20 times more distended. Because these diligent TDLUs are just sending in fluid and sending in fluid. Sometimes it's called milk. Sometimes it's called cyst fluid. Or it's not even a cyst yet. so we call it duct actasia. I just put an ultrasound over it. Of course you are going to see the fluid on ultrasound. And your and my job is going to be to answer the question, what produces the fluid? Is it micropapillary carcinoma? Is it papilloma? Or is it just fibrocystic change? Now, I put here a caliper. These are millimeters. This is not 0.1 millimeter anymore. It's actually 2 millimeters. 2 millimeter is 20 times more than 0.1 millimeter. Here is the fluid. What do you think the pH value inside here is? It's alkaline. When the cancer fills the duct, then it's acidic. And sooner or later, the water is going to disappear from this fluid. It becomes very viscous, and it calcifies. What do you think it's going to look like on a mammogram? That's it. We call it secretory disease. Now, unfortunately, it's not a correct term. It's not a disease, but it's one of the hyperplastic breast changes. Apochromatoplasia, cysts, ductactasia, very nicely demonstrated on the mammogram. But please note that there is a nice harmony here. There is order here. Why? Because these are her own pre-existing ducts. When we are going to talk about neoductgenesis, then you will see many side branches. Unfortunately, the colleagues, the pathologists, still call it DCIS, but that's a huge mistake because it's a duct-forming invasive carcinoma. Then I'm going to mention to you that these are too many, contorted, no harmony, disharmony, and they're always bilateral. If you see these needle-like calcifications localized only to one breast, only to one lobe, don't look at the shape density. Think this is carcinoma. The benign is always bilateral, harmonious. You see, this is when the fluid petrifies, and that's what we were talking about. The normal duct system has the terminal ductolobular units, but the newly formed cancerous duct doesn't have TDLUs. This is 0.1 millimeter. This is 10-15 times more distended. Distended by what? The cancer. Here is the carcinoma. So the intraluminal pressure increases, distends the duct-like structure, and if we radiologists are lucky, then we can see these long Y-shaped calcifications. Good luck. We don't see it very often. Let me show you the normal, pleated, resting duct. Always look for 4 basic building blocks. This is a sleeping, atrophic TDLU. That's basic building block 1. And the duct, skinny, atrophic, that's number 2. The white is the fat, and the yellow is the fibrosis. This is normal. This is hyperplastic breast change. It has a lot of TDLUs. They were producing the fluid. So this is just ductactasia, normal. This one is distended too. Distended by the so-called solid cell proliferation. You see here is the cell layer that die into the lumen and in the central necrosis. We can see the calcifications. If I was asking you, what do you think the pH value of this central necrotic lumen is? You would say that in this necrotic central area, There are the nuclei as a result of apoptosis. What is in the nuclei? What makes you that individual person? DNA. And this means acid. So the pH is not alkaline, it's acidic. And that results in these ominous calcifications. And if we are lucky, then we see these Y-shaped, fragmented casting type calcifications. I hope you enjoy the 3D picture of micropapillary carcinoma. Watch out, that's not DCIS. It's a contorted newly formed duct-forming invasive carcinoma. Here, it's fluid production. Here, it's necrosis. And of course, this is going to give a different mammographic image. Now I invite you for a little intellectual exercise. When the contrast-mediated galactography outlines a lobe, and it strikes you that women should not have so many ducts. Why is it too many? They are formed by the cancer. Neoducts. And as you see the large number of filling defects, when the pathologist looks at it, those are going to be the micropapillary growth. So these are duct-forming invasive carcinoma, erroneously called DCIS. Next, I have a question for you. So far, I showed the ducts on the mammogram, and it was radio-opaque. But what if the duct is radiolucent? It's right in front of you. A huge lobe is outlined by what? Radiologists. What is radiolucent on the mammogram? On X-ray? Air and fat. This patient told me that she could never feed the baby with the milk coming out of this breast. The baby immediately spit it out. So it actually is milk which had too much lipid. Baby didn't like it. And if it's lipid, then it outlines the ducts and its branches. And we had this patient coming back again for 2 decades, and the mammogram looks exactly the same. But you go home and you're going to see this picture. Let me tell you the story. 32-year-old complains about breast pain. What do you see on the mammogram? How many of the 4 basic bending blocks you can see? This is a duct outlined by radiolucent material. This is a TDL outlined by radiolucent material. And this is fibrosis. And this is fat. Why does she have pain? She didn't have it a week ago. And it bothered her so much that she asked for an emergency mammography. What is this? Which one of the 2 options? Lipid or air? Now, unfortunately, doctors always think about diseases. There were colleagues who told, oh, this is a gas-producing bacteria. No. Don't do that. Don't. But it's air. How does the air go into the young woman's breast? You will be surprised. This case is from Sweden. This case is from Russia. Do you see the air filling the whole lobe? This case is from the United States. And as I mentioned to you, this one you can see also in the Arab world. What is this? What? You go home to Qatar and screen and Libya and wherever, and you see this. You have to be able to answer the question. Dear colleagues, this is air. It carries a very important teaching point for the women. This is the result of sexual foreplay. The boys are taking into their mouth the nipple, and they blow air into it. This is not a sexist comment or something like this. Is physiology. Tell the woman, Don't allow the boys do this, because this is one of the explanations why retroareolar abscess is developing. This is nothing to play with. So much about TDLUs and so much about ducts.